The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening or good morning, as the case may be, and welcome to another edition of the RX Question Lab. My name is Jeff Downing, and I am thrilled that you're here tonight as we dive into Step 1 nephrology. And, obviously, whenever we do this, this topic is always exciting. Love talking about how the kidneys work, all the filtering and balancing and keeping us alive without us even thinking about it. So, be a good night, and we're glad that you're here. And as always, I am joined by Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Sure. Thank you, Abraham Titus. I'm a hematology oncology fellow at the University of South Alabama. I've been working with Scholar RX for quite a few years now and have helped so many students such as yourself, master the boards, do well on these exams. And I'm excited to go over some nephrology with you guys today. So lots of high yield questions here, and we're gonna kind of take it one at a time and focus on what's the most high yield thing I can take away from this topic. All right, looking forward to it.
Our question labs are brought to you from the same teams that bring you Scholar RX and USMLE-Rx. Our goal is, we really want to help you, master material, not just memorize it. So I've got a special offer at the end of tonight's session. Plus, we are going to raffle off a free subscription to our RX 360 Plus product. So make sure that you stick around until the end. As always, if you have questions, you can let us know in the question box. We typically, pull a pretty big crowd for these question labs. So if we are able to get to your question, don't take it personally. We're going to do our best. Okay. So with that, we're going to open it up with question number 1. And one of the things I just want to point out here is that when we show you the question, there's something missing. And that something is the set of answer choices. And we do this by design. So part of what we try to hammer home during Question Lab is, you need to have a methodology for answering questions, right? It's really important that you understand subjects like nephrology. You need to have a really strong foundation of medical knowledge, but you also need to know how to methodically answer these questions, especially on test day. Okay, so what we are suggesting, this is one way of tackling USMLE style questions. It's not the only way, but we model this so that if you've got if you're looking for a method that you can try this out, or you can adapt it to your own test prep style, regardless, we want you to hone and sharpen your technique as you're also preparing for these big board exams. So our first step is we cover up the answer choices. And the reason we do that is we don't really want you to get sidetracked if you see a question or see an answer choice that you don't remember, or maybe it's a concept, maybe it's a drug, maybe it's a disorder that you're like, oh, I'm a little shaky on that. So we really want you to take these questions step by step, and that first step, covering up those answer choices. The second thing we want you to do is we want you to read the lead-in. And the lead-in is what the actual question is. Okay, so in this case, the lead-in is which of the following sections of the nephron most likely remains impermeable to water in this experiment. Reading the lead-in is important because, again, it helps you focus on the information and the data that you need to collect in order to make the right selection. Okay, in there are uh, the rare occasions when you don't even need to read the vignette. Sometimes the lead in is so straightforward that you only need to look at the answer options. But the main thing, the reason we want you to read these lead ins is that now when you read the vignette, you have a sense of what kind of question that you're tackling, what kind of answer you should be looking for. And so it provides sort of a map, sort of a compass, actually, as you're going through the vignette. Okay, so let's read the vignette. A researcher is studying the mechanism of reabsorption and excretion of various ions in the kidney. When synthetic vasopressin is given to test animals, a particular segment of the renal tubule remains impermeable to water. So again, the question, which of the following sections of the nephron most likely remains impermeable to water in this experiment? And as I pass it off to Abraham, I always want you to kind of think about, hey, well, can I figure out what that answer might be just based on what I've learned so far? So with that, I'm going to pass it off to Abraham.
All right, so lots of high yield things that Jeff was talking about there. I think it's really important to kind of consider, okay, what is important here? What can I take away from this question? And just like he said, the lead in is very important. And, as we look at the lead in, we can kind of have an idea of what we're thinking about and really build that foundation for as we get to the actual meat of the question. This is a relatively small size question, but you are going to have some really fat questions where they have lots of details and a lot of distractions. You don't want to lose this main question stem, the thought that you're looking for in that big paragraph. All right, so let's go through, let's highlight some keywords here, and let's talk about what they really want us to do. So again, I like to start with the lead in again, right? So sections of the nephron is most likely impermeable to water in this experience. So you may even know that just from knowing your, nephrology, anatomy / cellular nephrology to understand, okay, this is all I know about nephron. But let's look at the question. Let's try to see what they're trying to get at. Maybe they're talking about this, new thing that's going on, right? They're studying a mechanism of reabsorption and secretion of a bunch of ions in the kidney. When synthetic vasopressin is given, a particular segment of the renal tubule remains impermeable to water. So what is going on here? What are they talking about? And then really just asking what section in the nephron. This question can be relatively straightforward, but you want to kind of focus in on the specifics in this question. All right, so let's look at the options here. Let's take it one step at a time and let's try to answer what's going on. All right, so we have, again, classic 5 options here. I like to start with E and go to A just so I don't get tripped up or get caught on distractor too early. So option E, proximal straight tubule. Option choice D, proximal convoluted tubule. Option choice C, descending loop of Henle. Option choice B, collecting duct. And option choice A, ascending loop of Henle. Right, this is your classic step 1 kind of question where, it's asking you a little bit more of the basic science side of it. And I want you to think about what's going on. Really, the question is asking which of these sections of the nephron is impermeable to water. That's really what it is. The beginning part is there to kind of give you context to the situation, but really you just need that one line. This is one of those questions where you could probably answer with just a one line. So take your time, pick an answer, and let's move forward. Yeah.
Okay, so let us share the results. And it seems like we've got a pretty strong signal from the crowd that ascending loop of Henle likely remains impermeable. About a quarter of you went with the collecting duct, and And some of you went with the descending loop of Henle and the proximal convoluted tubule. All of you went with proximal straight tubule. Okay, so let us hide the results and reveal the answer. And the answer is indeed answer choice A, the ascending loop of Henle. Good job, everybody. That is a great way for us to get it started. But, all of these questions are, they have different levels of challenge, and whether, some of you may have gotten it right, but aren't sure why you got it right. And some of you may feel like, oh, I think I knew that. And I picked the wrong one. Regardless, really, lock in here as Abraham walks us through the explanation.
All right, great job, guys. Again, the good starter question. This is kind of the base of nephrology you want to follow on. It's all about the nephron. You want to know the details of it, know the parts of it, and know, what each of it does. The ascending loop of Henle is going to be the part that's impermeable to water. Okay, so let's go through. I like this picture here. It's a great one. It is talking about the hormones that act on the nephron, and it's straight from first aid. So I think it's really high yield. You guys can go back and refer to this. So it's important to know where each of the hormones act on the kidney, but also understanding the different parts of the nephron and understanding what kind of happens at each part. And these little boxes that kind of show, okay, sugars, amino acid, sodium comes through. You have your calcium, magnesium here, your sodium, potassium, chloride transporter. So all these different areas of the nephron kind of show what is going on. Generally, anywhere where I see sodium, you assume water is following the sodium. That isn't true, particularly with the ascending loop. Okay, so the ascending loop has these things called the thick segment and the thin segment, but generally that area is impermeable to water, and even says that permeable only to salts in brackets there. And that's an important concept to understand. Most of the nephron will always try to absorb water, especially the collecting duct when they talk in the presence of ADH. Right? The question mentioned something about the patient receiving synthetic vasopressin. Vasopressin is a big fancy word of saying ADH. So when they have synthetic vasopressin, and on the bottom right here you can see that works mainly in the collecting duct to absorb more water back into the body. And you can read these little descriptions and take your time and kind of really study these things. But this question just kind of wanted to prime you to kind of take a look at the nephron and really dissect it. Okay, what is happening in the glomerulus? What's happening in the PCT? What's happening in the descending loop, the ascending loop, the distal convoluted tubule, and then the collecting ducts and collecting tubules. So this is exercise to go through, and really I used to just draw it out myself on a piece of paper. I would study it, and then I would try to remember. Very important. You may feel like, oh, I'm like doing a lot of basic things, but really a lot of questions will expect you to have a really strong grasp of the normal before the pathology comes in. Before we say, hey, they're missing aldosterone. Oh, ADHs are not working. You have to know what the normal is. And that's why I think this picture is great. I think that understanding the nephron is important. And this question is asking, okay, in physiological situation, which will not be permeable to water, which is the ascending loop. And it's kind of a factoid question, but it is important and worth definitely studying. So great job, guys. Questions do get a little harder after this, but great start to the day.
Okay, yeah, this is a good way for us to kind of reorient ourselves, and having that graphic as well too, because a lot of this centers around what we're seeing here within the nephron. Okay, so let us move on to question number 2. Let's see if we can keep up the momentum here. So again, we have covered up the answer choices, and we're going to start with the lead-in. Which of the following adverse effects is most likely to occur with this new medication? Okay, so again, we know that as we get into the vignette, we're going to be trying to think, hey, okay, there's a new medication. What's that medication for? What problems might arise from its use. So again, it's that lead in first. Don't go wandering into the vignette before seeing what it is that you're going to be trying to answer. Okay, with that, let's go to the vignette. A 50-year-old man with a history of hypertension comes to his physician with new onset pedal edema, pedal edema, and orthopnea. Cardiac auscultation reveals an S3 heart sound. He is prescribed a medication that inhibits the renal sodium-potassium chloride symporter. So, which of the following adverse effects is most likely to occur with this new medication? Think, if you've got one in your head, think about it, or go down to the question box. Let us know what you're thinking as I pass it off to Abraham.
All right, so we got another style of question here, and this is talking about a new medication being started, right? So let's go through, let's read the lead in, and let's try to highlight what's the most important parts of this question so we can get to the answer. All right, so most likely to occur with the new medication. So come on, this is a part of pharmacology. This is understanding drugs, understanding what it does to the normal physiology. Okay, so I go through the question. You got a 50-year-old man, sure, history of hypertension. Okay, that's important. New onset fatal edema and orthopnea. So what does that mean? What is the auscultation showing an S3 heart sound mean? So really trying to tell us, oh, something's going on, right? He has known hypertension, but he comes in with all these new findings. And then on physical exam, you hear this S3, right? Going back to our cardiology, S3 should mean something to you. Now they start this new medication, and they even tell you, hey, this is the mechanism of this medication. It's a renal sodium potassium 2 chloride symporter. So it works to block that. So what does that do? What class of drugs am I picking? And generally, what are the side effects I know of that class of drug? They have a couple clues here that kind of point towards it, the indication in terms of what the situation is, the picture, and really they give you the mechanism. So a lot of times they can ask you the mechanism, but they give you the mechanism, they give you the situation, and you have to just know the drug. And then you think about, okay, what are the side effects? What adverse effects can occur in this situation? So let's go through, let's put the options up. Let's talk about this a little bit. Let's rule out some options and let's figure out what the answer could be. So again, classic 5, I like to start with E, hypocalcemia. Option choice D, hypermagnesemia. Option choice C, hyperkalemia. Option choice B, hypercalcemia. Option choice A, crystalluria. Again, you may see certain things that occur, but really, which of the following adverse events is the most likely to occur? And which is the one that, and we're going to talk about some of these as well, is not going to happen in this situation. So think about the drug. If you guys know the drug, you can drop it in the question box while we try to figure out what the actual side effect of this is. So take your time and let's try to pick the right answer.
Okay, here we go. We're launching the poll. So hopefully you've already got a good read on this one. Just got a few more seconds if you haven't pulled the trigger. Okay, let's close the poll and share the results. So let's see. Once again, we've got a pretty big number behind one of them. Hypocalcemia earned 38% of the vote. Almost a tie for second between hypercalcemia and hyperkalemia. A few of you went crystalluria, and a few of you went with hypermagnesemia. So, good, interesting spread here. So let's go ahead and hide the results, and we'll share the answer. And the answer is answer choice E, hypocalcemia. So again, good job, everybody. We've got a couple of questions under our belt now, and this is another one where good positive response. But about 2/3 of you didn't get this one right, so that's okay. This is all about learning, right? All about preparation. So didn't get it, that's all right. Abraham is here to walk us through it.
All right, great job, guys. Again, a trickier question than your last one, multi-step question. You not only have to figure out the drug based on the history and the mechanism they're describing, but also you have to understand the side effect of the drug. Okay, and I saw a lot of you guys drop different drug names in the question bank, in the question box, and most of you are correct. We are talking about loop diuretics, furosemide, and all of its cousin drugs in that category of loop diuretics. How do I know they're talking about loop diuretics? They're talking about particularly the way they describe the mechanism. It inhibits sodium potassium 2 chloride symporter, and that is located, if we look at the previous picture, it's actually located on that loop. And when we kind of understand how these drugs work, you want to understand where are the nephrons working. That's why I think that physiology and understanding where that is, and if you just draw it out and put where the hormones are, where the drugs act, really just helps build that picture. Somebody said thiazide. Thiazide's not a bad guess, but that's not the mechanism of thiazide. Thiazide works in a whole different mechanism, and that's not how they would describe the situation. Okay. Now we have the drug now. Okay, so we have that we're dealing with our loop diuretics, furosemide, bumetanide, torsemide, and those are the whole classes. Let's break down which options make the most sense and which ones doesn't. Okay, we'll start with some of the ones that are the lower percentage ones. Hypermagnesemia, right? Loop diuretics actually cause a loss of magnesium, so not gaining. So you'd be hypomagnesemia, could be a correct answer, not hyper. Okay, so you lose magnesium. What about potassium? Well, would I say a loop diuretic is what I call a potassium-sparing diuretic? It's not. Loops and thiazides lose potassium. That's the classic feature of these diuretics. Potassium-sparing diuretics have the specific name. These are my spironolactone, eplerenone, triamterene, amiloride, those special drugs that actually spare potassium. So those are the ones that would cause hyperkalemia. So option choice C would be if I was thinking about potassium-sparing diuretics, which is not in the situation. And crystalluria, again, not typical for this. You're going to think about drugs like acyclovir, oxalate, high like that can cause that, which can cause crystals, not necessarily with a loop diuretic. Okay, so hyper or hypocalcemia. Those are the two common ones that everybody kind of got stuck with, and it's understandable. Those are the two extreme ends of the situation, and it does get tricky. I used to mess this up all the time. Which one is high, which one is low. So the important thing to remember is that loop diuretics cause low calcium. Okay, remember the L in loop is low calcium, whereas thiazides cause hypercalcemia. Okay, so thiazides, the T in thiazide, so think up arrow, causes hypercalcemia, whereas the L in loop diuretics, L low, hypocalcemia. It's my way of remembering it. Everyone's got their own way, but that's a classic question. USMLE loves that for some reason, and they're going to keep hitting on that. So you want to understand calcium is going to be how you differentiate loops and thiazides in a lab setting, but the mechanism is really what's you need to understand. The mechanism of a loop diuretic in this situation. Okay, so great job, guys. If you didn't get it right, don't feel bad. Putting it in this, look at the clinical situation. This patient has a new onset heart failure. That S3, the new onset pedal edema and orthopnea really fits the picture of a heart failure, and he has pulmonary edema. So you want to treat that pulmonary edema by giving a strong, fast diuretic. Furosemide is a great one, which we use IV sometimes, and the side effect is hypocalcemia. So great job, guys. If you have any questions, you can drop it in the box, but this is the real learning point from this.
Very good. So we are at the halfway mark tonight. So want to take a quick stretch break, and just sharing some quotes from USMLE-Rx users. These are the reason why we build these tools are to help students like you. And what I love about it, is that for med students, you're not just preparing for one exam. You're building knowledge that needs to stick with you through step 1, step 2, step 3, and honestly really through your entire career. And that's where USMLE-Rx really shines. We've got the Rx bricks to give you that conceptual framework to understand why things work the way they do. We've got a lot of bricks here that that tackle nephrology, right? So when you see one of these questions 6 months from now, or when you're on your internal medicine rotation trying to figure out why a patient's electrolytes are off, you have that foundation. Questions and the questions we use here for Question Lab are all from QMAX, and they're designed to to think like the actual USMLE. They're testing your ability to apply knowledge and not just recall it. Now we have over 5,000 board style questions, so you get that the repetition, the pattern recognition. That's so crucial for exam success. And you get a lot of the detailed explanations. And to me, Question Lab works because of Abraham, because you have someone who has been through this and can walk you through it and explain why the right answer is right and why the incorrect answers are wrong. So having those detailed explanations are important so that you really understand. So in any case, we've got a special offer for USMLE-Rx that we're going to reveal at the end of tonight's session. But just keep in mind, learning isn't one size fits all, especially as you're settling into new routines and rhythms this semester. But having tools that grow with you and make you a better critical thinker, that's invaluable. We work to do. Okay. With that, let's go ahead and launch question number 3. Again, we've got 4 questions tonight, so we're starting the second half, and we'll see if the challenge raises a little bit, right? So we've got those answer choices covered up, and I'm going to read the lead-in. Which of the following is the most likely explanation for the limited response to potassium administration? Okay, so you already know what's happened, within this vignette. So now we need to, really kind of, paint the picture. What's happening here? What's going on with this patient? So with that, we need to go to the vignette. A 45-year-old man is brought to the emergency department after losing consciousness. After he regains consciousness, he begins to experience tremors and delusions. There's no vomiting or diarrhea. Family members indicate that he has a long history of heavy alcohol use with multiple episodes of withdrawal. His potassium level is 2.9. ECG shows U waves. A couple of hours after the administration of potassium intravenously, the serum potassium level rises to 3.0. So again, which of the following is the most likely explanation for the limited response to potassium administration? See if you can formulate a hypothesis in your head as I pass it off to Abraham.
All right. So we got another level up question. So this was a little bit trickier, and I want you guys to kind of take everything and kind of get a good understanding. This is not one that you can really get to the answer just by reading the lead in. You want to see the full picture. Okay, so let's go through, let's highlight, let's try to figure out what's going on in the situation and try to build a hypothesis like Jeff said. Okay, so most likely explanation for the limited response to potassium administration. It's a very interesting way. It's not something you really think about. Okay, so we have a 45-year-old guy, came into the ED, lost consciousness. Okay, so why did he lose consciousness? We don't know. He's has tremors and delusions. Okay, so there's some things that should be clicking in your mind when somebody just comes in, wakes up, and has tremors, delusions. No vomiting or diarrhea. Okay, and he has a long history of alcohol use. Okay, that probably explains a lot of the symptoms. And he's had withdrawals before. Okay, now we get to the really nephrology part. Potassium was 2.9. Remember, 3.5 to 5 is your normal range. You have your labs available next to you. That's going to be the number they give you, 3.5 to 5. It's low. EKG or ECG shows U waves. Okay, what does that indicate? And they give him potassium IV. So you would think they would give him enough to replace it. But really, after giving the potassium, it only goes from 2.9 to 3. It's still not even at the normal ranges. So why did he not have a significant response to the potassium they gave him? So this is a concept that a lot of you guys may not have exposed to, but this is a little bit higher level difficulty. It's still step 1. It's still a basic science question, but it's expecting you to kind of think a little deeper. And these are the kind of questions where you need to really get a deep understanding of what's going on. Okay, so take your time, think about what could explain this best, and let's look at the options. All right, so we have our options here. Option choice E, volume depletion. Option choice D, metabolic acidosis. Option choice C, hypomagnesemia. B, hypocalcemia. Option choice A, chronic kidney disease. So if you haven't heard of this concept before, that's okay. But if you have, there's like a classic thing. It's like you learn it and then you know it. It's one of those things where if you've never been exposed to it, I think it's a good concept to understand, especially early on in your training. You learn from step one, it's going to stick with you all the way through. It is something that they do ask you while you're rounding in the hospital. Nephrologists love to ask this question. So, this is something that I think is very high yield to know. And the fact that it's in your step one Q banks means that it's making its way to general knowledge at this point. So you need to know this. So take your time, read through the question. The main idea is the patient got potassium for his potassium level at 2.9, but only went up to 3. Why is that? He has a history of alcohol use, and he has like these tremors, illusions. Okay, sure. So why did it not go up that much? Take your time, and let's try to get the best answer possible.
Okay, we've launched the poll. And we'll share the results. Okay, we'll see answer choice C, hypomagnesemia, pulled in about 42% of the vote. Metabolic acidosis, about a quarter of the vote. And then depletion and chronic kidney disease, kind of pulling up the rear with hypocalcemia, getting a handful of votes. Okay, so with that, let's go ahead and hide the results and reveal the answer. And the answer is indeed hypomagnesemia. Answer choice C. So great job, everybody. We're doing really well. This is this is not the easiest topic. So you guys are really performing nicely. If you didn't get it, or if maybe you were flipping a coin between this one and another answer choice, that's okay. We're gonna let's spend some time working through the rationale. And for that, I'm going to pass it off to Abraham.
All right, guys, great job. This is definitely a trickier question and a concept that a lot of people don't really know right away, right? Something that you learn through questions or by studying, and it's a concept that's very important, right? So magnesium is really important in maintaining potassium levels in our body. So first of all, you want to understand the patient is an alcoholic, right? So hypomagnesemia is typically seen in heavy alcohol use, and you can have what's called renal wasting, right? The patients can have renal wasting of both potassium and magnesium. So it's not uncommon for an alcoholic to come in and you check their lab and their magnesium and potassium is both low. Second, mostly due to renal dysfunction from the kidneys and also just poor intake. Alcoholics aren't eating the most nutritious meals generally, so they'll have low amounts of potassium and magnesium being taken into their body. So this hypomagnesemia can cause issues, not only because of the magnesium side effect, but because potassium, right? Potassium is one of the electrolytes that, if you ask any nephrologist, they're going to watch really closely. Cardiologists, nephrologists, they always keep an eye on it because it plays with the heart. It can mess with the heart, right? And that's what this EKG is really trying to get you to show. A U wave is a typical symptom or a finding we see in hypomagnesemia, right? A U wave is essentially like when you look at your EKG, there's a particular area. You guys can Google a U wave later that starts dipping down and forming a U, and that's that U, and typically indicates hypokalemia. It's the opposite of that is a peak T wave. So I like to think about this. So U is a low potassium, and a peak T is a high potassium level. So understanding of potassium, how it changes the EKG, goes a little bit into the cardiology side of things, but it is very important, right? Electrolyte management is going to be the name of the game for nephrology, but just because it affects other organs, it's a multi-system question as well. Okay, let's get back to focusing on the magnesium. So we need magnesium because the magnesium itself works with the channels in the kidney to prevent potassium loss. So if the hypomagnesemia is not fixed, no matter how much potassium I'm giving this patient, I'm never going to fully replace it because his ability to hold on to that potassium is not present until the magnesium is also replaced. So he needs replacement of both magnesium and potassium at the same time. This is very important in the clinical practice because a lot of times when we see these situations where patients low potassium and they keep replacing it every day, but it's still staying low, you have to be like, hey, someone needs to check his magnesium level and replace that as well. That's an important thing. The magnesium works synergistically with the potassium to keep that level up. It prevents the kidney from losing the potassium. That's a very important thing. Let's look at the other options. Let's kind of make sure those aren't the situation. So volume depletion. Okay, so volume depletion, sure, you can have some hypokalemia and metabolic alkalosis, which can be present when a lot of people take out of the diuretics, but it should get as soon as potassium level shouldn't prevent it from going up. Chronic kidney disease is actually, if I give potassium to somebody with CKD, their potassium level will jump more than I expect to. So if someone with a normal kidney, I give so much potassium, it's going to, let's say, double. It would go triple if I gave it to a CKD patient. The idea is that their kidneys just hold on to more potassium. Hypocalcemia is not going to affect potassium. It doesn't have that same relationship with magnesium. Now, a lot of people pick the metabolic acidosis. Metabolic acidosis will by itself drive that potassium extracellularly. That's that hydrogen potassium exchange is going on. So it's going to cause hyperkalemia, not hypokalemia, and doesn't have that typical association. So good thoughts, guys. A lot of important points there. But the most important thing is if I'm replacing potassium and it's not responding, always check magnesium because that's likely the cause. But great job.
Okay, nice work, everybody. And what do you know? We are here at the finale. Question number 4. So you guys have done a nice job up to this point. Hopefully you've already learned a few important tidbits or a few important pearls that will help you on test day. But we really want to close out strong. So we've got question 4 here, final question of the night. And again, we've got a raffle coming up here along with a special offer for those of you who stick around. Okay, so let's go ahead and get started. So again, we've covered up those answer choices, and you can see that it's one of those significant USMLE style vignettes. So when you've got those long vignettes, you may be tempted, you may want to start there, but it is important to jump down to that lead in and figure out what is it that I'm looking for. So again, the lead in, which of the following is the most likely cause of this patient's acute kidney injury? Okay, so that's pretty straightforward, and we know that the patient has acute kidney injury. So with that, now we need to figure out the backstory. So let's read the vignette. A 72-year-old woman hospitalized for osteomyelitis is evaluated on day 4 in the hospital for worsening renal function and low urine output. On day 1, she received vancomycin and ceftriaxone. On day 2, she underwent operative bone debridement, during which her blood pressure dropped to 85/60, and then recovered with the administration of normal saline and vasopressors. Her operative site appears normal today. Her blood pressure is currently 126/82, and she is afebrile. Serum studies show a BUN concentration of 48 and creatinine concentration of 2.6. Urinalysis shows a urine sodium level of 46, fractional excretion of sodium of 2.1%, and tubular epithelial cells. Okay, there's a lot there. So which of the following is the most likely cause of this patient's acute kidney injury? There's a lot to process, so with that, I am going to turn it over to Abraham to help guide you.
All right. Yep. Just like Jeff mentioned, this is a little bit trickier question. It's slightly higher level than the last one, but this is a very clinically relevant one. These are the kind of questions you're going to see from step 1 to step 2 to step 3. Very clinical, very, you're dealing with these kind of patients in the hospital and you need to know what's going on. So, the question is, what's causing the AKI, acute kidney injury, right? Why is the kidneys not happy? Something happened or something's currently happening that's causing the kidney to not be happy and cause some injury to the kidney. So you're going to see this all the time. I have a patient and his or her creatinine and BUN start rising and you're like, what's going on? Why is that happening? So you need to kind of be able to break down, look at the history, look at the picture, and give me an explanation for this. Okay, let's go through, let's highlight, and hopefully we can get to an answer based on that. So, most likely cause, okay? So again, this is thinking about etiology, think about why this happened. You have this elderly female, 72, came with osteomyelitis, okay? Osteomyelitis, right? Think infection of the bone. Was in the hospital. On day 4, they found worsening renal function and low urine output. Okay, make sure you keep track of the days. Now we're going back to day 1. Okay, on the day 1, she got vancomycin and ceftriaxone. Day 2, she had the surgery. And then during the surgery, her blood pressure dropped to 85/60. Okay. Then they gave her fluids, they gave her some vasopressors, and they got her blood pressure nice up, 126/82. And she's been afebrile. Now, if I look, serum studies show BUN 48, creatinine concentration 2.6, and then some of these other values that we don't often see, the urine studies, right? Urine sodium is 46, fractional excretion of sodium or FeNA is 2.1, and then we also see tubular epithelial cells. So a lot of good information here. There's a quick brief history here. Your blood, they're telling you urine finding as well. So a lot of key things that will help guide you to think about what's going on and what possibly could have caused the acute kidney injury in this situation. So let's go through, let's put the options up. Let's think about what the story is. Think about from day 1, day 2, and then now they're in day 4 and what's going on. So let's go through the options here. We have option choice E, renal ischemia. Option choice D, post-infectious glomerular nephritis. Option choice C, autoimmune glomerular injury. Option choice B, adverse effect of vancomycin. Option choice A, adverse effect of ceftriaxone. Now, multiple of these, you can say, hey, I can argue that this may be the answer. I can argue that this may be the answer. But really, one key thing is going to be the best answer or the most likely cause. Because we don't have a crystal ball, we can't predict, hey, which exact thing is the cause of this kidney injury. But based on the story, there's one that's the likely contributor or the culprit in the situation. So take your time, go through the question, read it again if you need to. Look at the timeline, look at what was given, look at the situation, and then look at the labs and the urine findings. All right, and when you guys feel ready, you guys can pick the answer.
Okay, so let's go ahead and share the results. And let's see. So pretty much a 2-horse race, according to the crowd here, between renal ischemia and adverse effect of vancomycin. Some folks thought it was adverse effect of ceftriaxone, and a few with thinking maybe autoimmune glomerular injury or post-infectious glomerular nephritis. Okay, well, let's go ahead and hide the results and reveal the answer. And the answer is indeed answer choice E, renal ischemia. That is clean sweep for the crowd. So nice work, everybody. These are some difficult questions, and you guys pulled it out. If you didn't get this one right, or something kind of pointed you in the wrong direction, that's okay. This is why we're here. We want you to make sure that you get these questions right on test day. So I'm going to turn it over to Abraham one more time to walk us through it.
All right, so great job, guys. Again, this is another tricky one, but you guys got it still, so great job, hats off to you. Let's break it down. Let's think about what's going on, okay? So I'll go through the options here. I'll try to explain, why the situation is different than each one. And also, really, everyone loves to blame vancomycin, and I think that's not an uncommon answer, and that's why I said that you could have contributed, but really the timeline is what's really important in this situation. Okay, so let's look at the story. Let's see what's going on. So this patient, osteomyelitis, we're already dealing with an infection. Dealing with an infection comes in. Okay, on day 1 got vancomycin and ceftriaxone. Okay, so it hasn't been that long, but day 1 vancomycin ceftriaxone, and had the debridement and had hypotension at that time, right? So hypotension during a surgery or anything like that leads to low blood pressure. Low blood pressure can lead to low perfusion of blood to organs. Particularly kidneys are very sensitive. Kidneys love fluid. They're thirsty organs. They need a lot of pressure, a lot of perfusion. So as soon as I get hypotension, that you can guarantee that in a couple of days, my kidney is going to be injured, and you're going to see it on the labs, right? It's always a little bit of lag behind there. You got fluids, pressors, and they got them nice and normal blood pressure back up. But then you look at these labs, and I want to interpret these labs, and I'm going to talk about some key findings that you're going to see in these labs that, you got it from this question, but sometimes they can ask you more details, or they can ask you in a harder way where they expect you to interpret these labs without the history, and you have to understand what I'm talking about. So first, let me rule out why the other options are incorrect. We already know it's renal ischemia, but I want to know why these labs are important and what they're pointing at. Okay, so starting off, let's start with the top, ceftriaxone, right? So ceftriaxone can cause some kidney injury, not typical, but this is something called AIN, acute interstitial nephritis. So if you see ceftriaxone or any of the penicillins causing kidney injury, it's typically associated with a fever, rash, and then the urine's going to have leukocytes and eosinophils. Eosinophils in the urine is classic presentation of ceftriaxone-induced kidney injury, which is acute interstitial nephritis, AIN. It's a different entity, not what's going on here. Vancomycin can cause kidney injury after a long time. Usually you want to think about it in patients that have prolonged after more than 7 days, okay? And it's usually in very sick patients, like patients that are like on death's door. You take it, you give me like more than a week of vancomycin is when I'm seeing the kidney injury. But a couple of days of vancomycin, you can make an argument, but it's probably not the primary cause of the situation because of the story. Autoimmune, not many of you guys picked that, but you want to think, right, so autoimmune glomerulonephritis, we're thinking about things like things where your body's making antibodies that go into cause it. So this includes your IgA nephropathy, which has that recent viral infection. 1 to 2 days later, they get the bloody urine. Not really fitting that picture here. And those are going to be more, that proteinuria, hematuria picture, not just being with creatinine elevation and talking about sodium and things like that. Post-infectious glomerulonephritis, this is something that typically takes about 2 weeks after infections, typically with staph or strep, and hematuria, proteinuria, which is not what they're describing. Okay, let's talk about renal ischemia. Let's talk about what this is. So the diagnosis here is ATN, acute tubular necrosis. That's that muddy brown casts, and those are the buzzwords that they use sometimes in the question. But really the picture here is that it's not a problem of just, oh, the kidney didn't get enough fluids, so that's why you're having kidney injury, but you didn't get enough fluids initially, which led to tubular necrosis, death of the tubules of the kidney. And that's why you have that high urine sodium and that high FeNA to show that, hey, the patient is actually not able to absorb a lot of that sodium back into the body. And that is what really points towards ATN, right? Sometimes they give you situations where, oh, the patient is back to normal blood pressure now and he's receiving fluids. Why is the kidney still injured? Well, because you have necrosis of the kidney. It's going to take some time for the kidneys to heal, right? If I'm hypotensive, my renal function can go up, but that usually, as soon as I fix that with some fluids, it should fix itself. But if it doesn't, then there is some type of necrosis that happens. That's where ATN comes in. So ATN is acute tubular necrosis, typically due to ischemic injury or toxins, which then lead to like low urine output. Your BUN and creatinine both go up, and you have that elevation in your FeNA, which is a fractional excretion of sodium, and your high urine sodium because you're not able to absorb it back into the body. Very classic, very important high yield point there. And really interpreting that, sometimes they can just give you just the labs and they expect you to understand, hey, this is an ATN I'm dealing with. So as you do more questions, you'll get more comfortable with those situations. But really these lab values are very important, especially when you get into step 2 and step 3. Step 1, really the main focus is, do I know ceftriaxone causes AIN? Vancomycin takes about a week to cause kidney injury. And when I'm talking about glomerular stuff, think about proteinuria, not really sodium, and talking about that kind of stuff. I'm talking about tubule problems at this point. So conceptually understanding that is very important, but great job, guys, even getting this question. If you have any questions, feel free to drop it in the question box.